Let's get started by thanking our wonderful sponsors who make this show possible every week. We can't thank them enough. Age-related macular degeneration, or AMD, is the leading cause of adult vision loss in the U.S. It affects 1 in 14 over the age of 40. When caught early, there is time to take corrective action. Ask your eye doctor to test your dark adaptation speed using the Adapt DX Pro from Maculogix. With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you.
Vision Edge gives you less eye strain and reduced damage caused by blue light. We like to call Vision Edge sunscreen for the eye. It all starts with your highest level of visual performance, only achievable through scientifically proven Vision Edge.
Welcome back to part 2 of my interview with Dr. Greg Caldwell. In this episode, we dive deep into new technology and treatment for retinal and macular disease. If you're new here and you like our interviews, press like, subscribe, share, and hit the bell to get notifications of great new interviews. And please leave comments. Next is OCT, and we talked a lot about OCT, but I want to talk about if somebody has those subretinal neovascular membranes that we see on OCT angiography, there's about a 15 times greater chance for those eyes to turn wet. If you could talk about that, and what do you think should be done at that point? Because right now, they're not being treated with anti-VEGF in most cases or laser. And what should we do?
Well, the two ways I'm going to answer that is just, and again, it's through experience, is when you see them, follow them more closely, because you want to catch them early. And if they're starting to become exudative, then they'll eject them. So as soon as you start seeing a little bit of influid, they'll do an anti-VEGF, because that's what its indication is for. So closer follow-up is definitely one. Now, I worked with a retinologist very closely for about 5 or 6 years and learned a lot of my pathophysiology skills, learning about the layers and how a lot of this works. And then, so there is a group from Pittsburgh that comes up to my local town that are retinologists. And I became good friends because he, if I send over a maculon retinal detachment, it's usually a maculon retinal detachment. If it's exudative macular degeneration, we've built up a confidence with each other from sending something over. That's usually what it is. And if it's something surgical or needs injected. So I start talking to him about these occult non-exudative choroidal neovascular membranes. And he's like, Greg, the problem is we just don't know what to do with it. Just like you said, Carrie, it's 15, I think it's 15.2, but 15 times more likely that they're going to bleed and lead into vision loss. And so I followed them via his advice. And within about, 4 months, my first 2 that I was able to detect bled. And I had some series of follow-ups of some angiographies. And so we've come to the conclusion, working with him, and I'm just going to use this as a disclaimer. You can't say this is going to happen all across the United States, but I follow them closely. And if I can show that net is growing pretty quickly in a rapid, maybe over about a 6 or 8 week, maybe 10-week time period, and I talk to the patient and kind of go over everything. If the patient goes over and he sees that this membrane is growing and it's obviously in the macula, which is a very serious place, and the patient is willing to take the risk of the injection, which would be maybe say endophthalmitis would be your worst risk, then he'll inject it on that patient. And we've been able to keep some people from losing vision, at least, in my opinion. They haven't done any long-term studies. We know that it's 15.2 times risk, but the patients that we've injected, and my N is probably 16, and none of them have bled to this point. So I like that track record if it was my eye. So
we do, of course, I'm sure you do also. We're heavy duty when we see that, very heavy duty in nutrition. So if they're using MacuHealth once a day, which is lutein, zeaxanthin, MESO-ZEAXANTHIN, we may use it 2 times a day, even 3 times a day. a la Michael Tolentino, who's a retina specialist, and of course will follow a very strict diet without processed foods, something that Dr. Chris Kenobi talks about. And, I interviewed him about staying away from processed food and eating real food. So with a very, very strict diet, stay away from sugar, a la Dr. Robert Lustig, who also has been a guest on the podcast. So we work very hard as far as nutrition and diet, and I'm sure, and supplements when people have this, I'm sure you do as well.
No, absolutely. We talk about diet, we say it from the podium, but you're right again. And I kind of mentioned it a little bit earlier, stay out of the aisles, eat those fruits and vegetables, try and maintain it. We just, it's just not eating a bowl of spinach a day. You really got to get serious about it. And like you said, get that glycemic index down, get that, when we talk about exercise, it's to, burn off some of that sugar, lose some of those fat cells. It all adds up a little bit here, a little fat loss here, a little exercise here, a little extra nutrition, a little supplements, not processed food. And all of a sudden, wow, now you got yourself, a less inflamed body, a less inflamed eye. And, if you give the body good nutrition, it will heal itself.
Yeah, and unfortunately, the USDA checks Americans' nutrition every 10 years or so, and about 92% of us are deficient in at least one nutrient. So the standard American diet, or the SAD diet, certainly needs to be improved.
Yeah, and I practice in the Altoona area, so it's really easy for me to always say, we talk about the SAD diet. I always say the SAD, the American diet, just like you said, the acronym being SAD American diet. I'm able to use SAD Altoona diet, so because we're about a bunch of chicken wings and French fries out here, so and potatoes are fried potatoes are not the best source of a vegetable, so.
We talked about dark adaptation before, like moving on to other technology. Just to go a little deeper into dark adaptation, how does the test work? What's when it's being performed? What is actually happening during that test?
Yeah, so there's two generations that are out there. So there might be patients or people listening that are going to a doc that has maybe had this since 2013. I think is when the first what I call microwave box hit the office. Literally, it's like a camera flash going off, and then seeing how quickly you can adapt back to a normal, being able to see the light and dark adapting. So there's that device that's out there. And then at the end of 2019, there was this big buzz. I remember being at the academy, and I always go through, and I as a lecturer, I want to know what's new and big coming out. And I remember the folks from MaculogX saying, "Oh, there's going to be a great release and this and that, and it's going to be exciting." Well, yeah, tell me what's going on. Oh no, I can't tell you. We've been sworn to secrecy. Then, yeah, why'd you bring this up? And then on January 1st, I was clicking through, I don't know, one of the social medias, LinkedIn or whatever, and I saw what the big, hubbub was about. Is that, and I always tease, if you don't like your technician, you put them into a visual field room. But if you really didn't like your technician, and maybe you wanted them to leave the office, but you didn't want to fire them, maybe they would just leave. You just had them do the dark adaptation with the old instrument, because you had to have a dark room. If a phone went off, like a text message, and it lit up the room, it could throw the test off. You had to have a whole separate room. It was really cumbersome. And then what happened in January of 2020, the virtual reality goggles come out, and literally, it was a blessing for 2021 or for 2020, because, we didn't have to like contaminate another room. We were able to bring the instrument right to the exam lane that they were in, and it made the room a dark adaptation room. So you brought the device, which was a headset. The headset actually talks. It's got this onboard technician they call Thea, which I believe is the goddess of sight. And it talks to the patient, which gives it a really good, consistent, every single time. Close your eyes, open your eyes, look at the light. But long drawn out sense, Carrie, it's a flash of light that goes off goes off superior, but you're seeing it inferior, right? Because everything's kind of backwards. And it's about 5 degrees off the foveola. And what it's doing is big flash of light, like a camera flash, and then it shines a dot in there, and it just sees when the patient can recover. And they're literally dark adapting and seeing how quick. And it's off to the side because it's the rod intercept using the rod photoreceptor. So flash of light, and then how quick you recover is the simplest way of putting it. But a really advantageous instrument.
How is it different than photo stress recovery?
Yeah, I'm going to have to maybe lean on you on that. I know that photo stress recovery was kind of talked about back in the time whenever I was graduating. It would be, just shining a light in there and just seeing how quick they recover. But that's all I know. So I'd lean on you on that one.
Yeah, there was an instrument for a while. It looked like a hairdryer, and it would shine a really bright light into somebody's in each eye separately, and then it would just count until the patient could see the number, and that would give them the photo stress recovery, and that was also supposedly correlating with early macular degeneration, but unfortunately that instrument isn't available anymore.
Yeah. So this would be, in a sense, a much improved instrument to be able to do that with probably a little bit more higher sensitivity and specificity. So
let's talk about genetic testing. First, let's talk about inherited retinal disease.
Yeah. The quick on, skinny on genetic testing right now is, and then when I lecture, I have a couple slides in there, and I have to give the slides, a little kudos to Dr. Chris Putnam. He was the one that taught me about, these genetic testing. And the key here with genetic testing, whether it's the retinal hereditary conditions or macular degeneration, is that if you do these swabs and you send it off to a lab and it comes back positive, all that tells you is you have the risk allele. And that doesn't mean that you're going to get the disease. But what it does is it just kind of says that the gun is kind of loaded and ready to go. And the last thing that you want to do is have something to pull the trigger. And we talked about a lot of those things that are out there that pull that trigger, Carrie. Those are those risk factors that we were talking about. We were talking about the alcohol and how it depletes all the vitamins and minerals. We're talking about being overweight. We're talking about poor nutrition, the blue light from sunlight, and maybe even from, long exposure. Those are those risk factors that if you have those risk alleles, that can pull the trigger. But not everyone that tests positive is going to develop the condition. It just kind of tells you that the gun is loaded. Just try not to do anything to trip that trigger.
Now, how about genetic testing for macular degeneration?
Yeah,
talk about that.
Yeah, the same thing. It's whether it's a hereditary or degeneration. Again, you can test for it. And that's where, I did the ancestry, .com or whichever one I did, and we did the genealogy, and it was really, really cool. But that's where some of that genetic testing can get, they can find that you have those risk alleles, and then all of a sudden the patient starts getting all this information from all these companies. You should be doing this or doing that. The only thing I'd say is stay tuned. Genetic testing is going to be a part of this, but the key is whether you tested positive for a retinal dystrophy or you test positive for the risk alleles for macular degeneration. It doesn't mean you're going to get the condition. Those are the things that you want to then maybe at that point start just being careful, wearing those sunglasses, taking and doing proper nutrition. I think the confusing part is the genetic testing is, oh my gosh, I'm going to be blind. I'm going to get on the internet, read about it, and I'm going to be getting injections in my eye, or I'm going to have geographic atrophy. It's not a yes, you're positive, and yes, that's where you're going to end up. The key is you have, again, the alleles. You don't want to do things to cause that allele to become active, to which then activates the disease.
How about vita risk? If you have, you do the genetic testing and you're high in complement factor H and you don't have any arms too, staying away from zinc, and the opposite, then zinc is okay. What do you think about those studies, and do you follow that?
Yeah, I followed it, somewhat. You probably, being in this industry, you probably know a little bit more than I do. But again, yes, those are, if you have those alleles, you want to stay away from, from the zinc, because it can cause the wet macular degeneration to occur. And then obviously, then there's some safer, the higher zinc. I'm kind of a proponent to use lower zinc preparations. The 25 is what you need to have to be able to get that outcome of protection. 60 was pretty high, and if you go and you listen and ask people, they'll say, "Well, it was just to get the patent." And we do know that there's a lot of risk from zinc. The people that were in the AREDS 1 and AREDS 2 studies, there was a lot of dropout from those studies, and it was not due to the other, vitamins in there, but due to a lot of the zinc. So zinc can be bad, and that's why they put, copper in these formulations, because copper can, or zinc can deplete copper and create a copper anemia. So yes, a lot of a good thing can lead to some bad things. So you got to be careful with zinc that's out there. Yep.
Yeah,
absolutely.
because the original ARADS form was 80 milligrams of zinc, and there was some there was some side effects to that, and so some of the studies that were done is 25 milligrams and below, even if it's complement factor H, seems to be okay. And anyway, we need zinc because we need zinc, if we're not eating enough pumpkin seeds or really dark chocolate or oysters or things that have a lot of zinc in it, we do need to take zinc, because zinc is very important. There's 300 enzymes in the body that zinc is involved in, from digestion to inflammation. So zinc is important, but I guess the body could only absorb about 40 milligrams of zinc. So we want to stay away from anything over 40 milligrams. It's like the little Goldilocks theory. We just want just the right amount. So I thought those were interesting studies when they did that on zinc. Let's talk about macular pigment. Do you do macular pigment testing from as far as MPOD? And I know you've gone to the biophotonic scanner, but talk about first the MPOD, the macular pigment test, and the importance of testing macular pigment and what the macular pigment is for. And then let's go into the biophotonic scanner. But let's start with macular pigment and the importance of that first.
Yeah, being a speaker, and a lot of the companies like for you to, obviously get, their technology into your practice. And Carrie, I can tell you, I tried multiple times to make, macular pigment testing successful in the practice. It's a subjective test. Just hard to get that reliable testing. Is it important? Absolutely. We talked about those macular pigments, right? We've said them, I think, multiple times, but it's always good to repeat: lutein, zeaxanthin, and MESO-ZEAXANTHIN. And those are kind of your first line. I talked about that inner retina, blocking and acting as a sunglass, and capturing that blue light, and then doing that free radical repair, sequestering those free radicals. So macular pigment, and the highest part is of those three macular pigments that we talked about, the lutein, zeaxanthin, meso, is in the macula and any other part of the body. And that's purposely, right? Again, to protect the retina. So knowing what those macular pigments are extremely important. And making sure that they're at high levels to protect that retina is extremely important. I was talking to Chris Putnam, and we said, well, you can do a macula biopsy to really get the true, but who's going to be biopsying their macula? And then there's all these MPODs, and then there's some other instruments out there, kind of OCT-like, but they're getting there, and then maybe it will be a part of the OCT to be able to measure someday. But I am full believer that yes, you need to know what the macular pigments are. And then, you can do some blood testing if you want, but then that's kind of invasive and kind of a pain in the butt.
We'll talk about this biophotonic scanner. Does it correlate with macular pigment? Are there studies? Are there enough studies?
Yeah, I think there's enough studies that are out there, at least enough that I put it in my practice. I've seen and heard that I've read a bunch of studies. I've heard that there's over 90 studies. There was actually a paper by Arvo in 2016. They're the ones that that's the paper that convinced me that they looked at it, and I read their poster, and they basically said that the biophotonic scanner, which works on Raman resonance spectroscopy, and it's using blue light that shines into your hand. Really simple tech, really simple, but an amazing technology. I hate to dumb it down, but yellow and blue make green. Blue light goes into the hand. Carotenoids are yellow, and the amount of blue light that comes out, it measures it. Now, I heard that there's like $100 million of technology put into that little scanner that makes it the football size so that you can put it in your office. But going back and saying what Arvo was able to do in other studies that are out there, if the patient, let's say, is not taking MacuHealth, which is very specific for the 3 carotenoids that we were talking about, if they're not really taking any supplementation, if they scan low in their hand, the studies have shown that it's equivalent to what would be found in their serum, which is then equivalent to what's found in their eye. So obviously that could be a little bit flawed if someone is, like you said, taking 3 MacuHealth. They're going to scan a little higher on the, because they are taking a carotenoid, they're going to scan a little bit higher in the scanner, but maybe not as high as if they were kind of like fully nutritionally being treated with carotenoids, polyphenols, and the flavonoids. So the first thing is, yes, I'm convinced enough that if someone comes in and they're just kind of living, and I measure them eating, maybe taking a 1 a day from, their Rite Aid store, and I scan them in their hand and they score low on the scanner, that there's enough tests out there that are going to be low in the serum and then low in the eye. Now, what I like about the scanner, it's almost like the hemoglobin A1C for people with diabetes, because the scanner, and it's really cool to hear patients. I'll say, "Oh, I'm going to score see how you're doing with your fruits and vegetables," and it's almost, I become priest-like. I got the collar on, and all of a sudden they're going to be like, "Oh, it's probably not going to score high because I had a couple of shots of whiskey last night and I had some chicken wings." I almost become like, it's almost like a confessional. And I'm like, well, that's okay that you told me that. And it was really good to hear that. But this is really a 60-day biomarker, and it's actually a true biomarker. There was a 10-year study by Yale University that showed that this is a biomarker, not a risk factor, but a biomarker for food intake and health, your diet and fruits and vegetable intake. So long story short, yes, I believe that when you scan the hand, that it is a correlation to what you would find in serum, and that that's what you would find in the macula. And it hasn't just been proven one time, it's been proven multiple times. And really the Arvo study is the one that really convinced me, which was back in 2016. And they actually said it was equivalent or better than maybe an MPOD.
Yeah, I think that Paul Bernstein did that poster.
Yep.
And he's a pretty famous ophthalmologist.
Yeah.
Famous scientist. Age-related macular degeneration, or AMD, is the leading cause of adult vision loss in the U.S. It affects 1 in 14 over the age of 40. When caught early, there is time to take corrective action. Ask your eye doctor to test your dark adaptation speed using the Adapt DX Pro for maculogix.
Macular degeneration is a leading cause of vision loss, with 15% of Americans being at risk or already affected. Scientific evidence proves that by using MESO-ZEAXANTHIN, lutein, and zeaxanthin together replenishes the macular pigment and promotes healthier vision. This formula comes in only one product, MacuHealth.
Let's talk about treatment, and we'll start with carotenoids, going back to the carotenoids and talking about outer retina. Joanna Seddon did a study, and she showed that people who had a diet high in carotenoids lowered their risk of macular degeneration from by about 43%. So, of course, we want the rainbow, but carotenoids are important. What kind of vegetables and fruits do we find carotenoids? Lutein, zeaxanthin, MESO-ZEAXANTHIN, not so much in the diet. We need to lutein to convert to MESO-ZEAXANTHIN, or we have to supplement. But if you could talk about also plasma levels, because when they've done plasma levels of studies, and they looked at plasma levels of lutein and zeaxanthin, there's studies that show up to people with the highest amount of zeaxanthin in their plasma had a 93% decreased risk of macular degeneration. And lutein was, I think, somewhere like 79%. But of course, if you eat the food, it's only around 43%. So that shows it's not necessarily what you eat, but it's what you absorb. So how can we absorb these vegetables and these carotenoids better, and where do we find them?
Well, I know there's a lot of docs out there that will say, there's lutein is, spinach and kale and all the specific and the different fruits and vegetables that have zeaxanthin. And you said it's very difficult to, I think, like shrimp, the what makes shrimp, I think pink is what makes the MESO-ZEAXANTHIN. But it comes down to what I was saying about everything in moderation. So if you're trying to get lutein, trying to get zeaxanthin, then obviously, your green vegetables. So that's why you hear a lot of spinach and a lot of kale. I'm not a big iceberg fan. That's not the best thing. It's more water. It's not that strong with lutein and zeaxanthin. So kind of those vegetables that are out there, kale, spinach, and then you want to move into getting all your, to kind of round everything out. Anything that's colorful, green peppers or yellow peppers, red peppers, tomatoes, bananas are yellow, grapes are red and green, carrots are orange, so you want to kind of eat that whole spectrum. And by eating that full spectrum, you'll get that. And you're right. Absorption is huge. I lecture with a pharmacist, and we always get this question, whether it's, omega-3s, are they ethyl esters, are they triglycerides, and, supplementation, like what's the best way to, what's the best supplements out there, so on and so forth. And she's the one that taught me, she'll say, look, the best way to get, any carotenoid or any, fatty acid is from the natural source. But then the natural source needs to be nutrient dense. Your body needs to be able to absorb it. And sometimes, there's a lot of out there with the gut microbiome. That can be an issue that's out there causing absorption. And so you're right. You could be eating the right things and your body just can't absorb it, or you could be eating the right things at a low amount and your body's becoming a super absorber. But you got to be eating the fruits and vegetables. That's the key. Again, you said it, the processed food. Let's stay out of the aisles.
One of our colleagues, Dr. Stu Richer, who's an OD PhD, I believe he's the optometrist that has published the most studies. He has a very, very famous study called the LAST study, where he supplemented with 10 milligrams of lutein. This was back in 2004, and he showed that you improve macular pigment. It actually improves some of the letters in the group that was supplemented. Glare was better, contrast was better. If you could talk a little bit about how we can improve actually good vision by supplementing, improving glare, improving contrast, improving sensitivity to light, and even something that is very interesting to me is hitting a baseball. Being able to see a ball better. A lot of professional baseball players supplement with carotenoids, lutein, zeaxanthin, MESO-ZEAXANTHIN, to be able to see the ball better.
Yeah, so we were all talking about kind of that structural side of looking at the OCT and all the bad things that can happen. But yeah, there's also with kind of that optical side, making that macular pigment, absorbing that blue light, we as optometrists, we use, Snell and acuity. And, there's big steps in there. There's contrast sensitivity that's out there. And, you can really, someone might be, let's say 20, 30-ish in a sense, and you can give them proper macular pigments. And, we talk about like refracting them with glasses, nearsight and farsightedness. When they're low on the macular pigments, those carotenoids that we're talking about, you can just improve their visual function. And most of the listeners out there are familiar with Snellen acuity, which is the big E and all that. If you use a different type of acuity chart, you could see a lot of shifting just by someone that might be, 20 years old. You're talking about a baseball player, and improving their acuity to the point where they might be able to see the kind of the spin on the ball. And then they talk about temporal processing that's out there. That's more getting into the brain. And by the time, the pitcher throws the ball, by the time everything processes, they have to decide. So it's really speeds up that processing part. And carotenoids can be a big part of that. So that's a whole other, issue that, you being, an expert in this and well-versed in this area, thank you for bringing that up, because it's more than what we just talked about. Yeah, absolutely.
And you bring that up, and lutein's in the brain and helps with cognition. We know that people on a Mediterranean diet do better with cognition. People on a Mediterranean diet have a lower risk of macular degeneration by about 40%. There's the hope. Lisa Renzi has done work in this area and has shown that maybe macular pigment can be a biomarker for cognition. Is there enough lutein? People are getting enough nutrition in their brain?
Yeah, and yeah, I agree with that. And there's a lot of studies going down with that. And one of the things I kind of want to piggyback on is, and it might have been one of your casts I was listening to, or I was reading about, I'm big into nutrition now and trying to help my patients out. And we know if we give statins to some people, that they start getting this dementia issue with the statins. And, the cholesterol is a fat, whatever that number is, our brains are 80% fat and it needs fat to run off of. And we start giving statins and depleting those cholesterol, because it could build up and create heart attack and stroke. We get that. But what I didn't realize until maybe about 6 months ago is those carotenoids that we keep talking about. We all hear about, water soluble type of vitamins, and, that might be like a vitamin C that someone takes. And you hear about the expensive urine, but these carotenoids that we keep talking about, they're fat soluble, and they get attached to the HDLs and the LDLs that are out there, and they have to get into the brain. The brain uses that, and that just takes that lutein and zeaxanthin into the brain, or more importantly, the lutein, and it allows with that cognitive function. And that's why a lot of this is connected to, macular degeneration, heart disease, macular degeneration, some diabetes, macular degeneration, dementia, Alzheimer. It's kind of funny how those are all kind of loosely associated or connected. That's out there. So yeah, lots of importance with that lutein and getting into the brain. And it's kind of funny, right? That brain is 80% fat.
I mean, there was studies that show that if you have enough lutein, if you have enough macular pigment, you have less computer strain. And then people actually sleep better, and they don't know if it's correlated or not, but that was something that was found in one of the studies, that by having enough macular pigment, we have more comfort when we're looking at a computer.
Yeah, and I would agree with that. I mean, we learned a lot with these yellow lenses and blue blocking, and seeing a lot that's happening out there with that. I am a scientist in a sense, but I'm more of a clinician. I like to use science. And to me, there's enough evidence there that, if you have proper, so let's just think about, we keep talking about these macular pigments, right? Lutein, zeaxanthin. When you look at the macula and it's properly has the proper amount, that macula is yellow looking. And, yellow absorbs the blue. So, yeah, I think that just kind of going down to something as, kind of, maybe not scientific, but as simple as, well, the yellow absorbs the blue. Um, so that's going to be then beneficial, that there's a lot of good things going to happen, and someone just might sleep better and they'll have less glare. I mean, it's just another optical lens in a sense in the eye. When it's missing, that's not a good thing because it creates other issues. And I would say, I would believe that, someone has proper supplementation, that they're going to sleep better.
Yeah, I mean, if there's more yellow, the more blue is absorbed. If there's less yellow, blue causes scatter. There's going to be more glare. People are going to be more comfortable when they're around light.
Yeah.
Let's turn our attention to omega-3s. There's been a number of studies that show that if you take omega-3s, you could decrease your risk of macular degeneration about 40% as well. What's your stance on omega-3s? What type of omega-3s do you like? Do you recommend omega-3s?
Yes, again, it's everything in moderation. To really narrow down to, do I have a favorite omega-3? The key is yes, as long as it's in its triglyceride form. I really don't want it in its, what is it, the ethyl ester form, or if I'm saying that properly. I just want to make sure, in a sense, that it's in the triglyceride form is the most natural form, and when it's the most natural form, it's the most potent. And we just talked about all this stuff with regarding, what are triglycerides? They're fats. They're good fats. And in this case, the omega-3s, and they're going to help fight inflammation. We talked about that way long time ago. And they're going to support a lot of mechanisms of everything that we talked about tonight. So absolutely, omega-3s in the triglyceride form. You asked me which form, the triglyceride form would be the way that I would advise people listening to this.
And vitamin D, there's been studies that show that having people with the highest amount of vitamin D compared to the lowest decrease their risk of macular degeneration, or at least early drusen, by about 43%. We know vitamin D is an immune modulator. There's been studies that show that vitamin D is helpful with insulin sensitivity. There's in the Journal of Neurology, I believe, it showed that there's a decreased risk and possibly memory function. Talk about vitamin D, macular degeneration. What do you think?
Yeah. Well, my biggest right off the bat would be, why are almost every day a patient will come in and my technician will be like, oh, that patient's on vitamin D. And the key is that there's scientific data out there of the things that you just mentioned, of the benefits. But I think the biggest thing, the reason why you're seeing this, is because you can measure it, right? You can measure for vitamin D, and then a patient will come in, and then if they, usually the primary care doc is measuring this, and if they're found to be low, then they'll supplement them. Now, my little issue or concern would be, and this is just me anecdotally, is, if a patient just tests low on vitamin D, they're probably low across the spectrum, but at least they're doing something. So a lot of the times when the patients come in and they're on vitamin D and I use the scanner, they still scan low. Maybe they scan higher than maybe the standard Alcina or standard American diet that we were talking about, but they scan a little bit higher, but it's kind of a monotherapy rather than that kind of A, B, C, D through K, essential minerals and vitamins, and then getting into the polyphenols, flavonoids, and carotenoids that are out there. But yeah, I mean, at least we're moving in the right direction, right? There's a big hole in healthcare. We kind of wait for end stage, but we want these, I'm glad that primary care docs and traditional medicine is moving into maybe more nutrient side of it. So it's a good start. So, but it's a needed, because there's scientific data out there that vitamin D, if low, can create, negative things that happen to the body.
A lot of diseases run together, like cardiovascular disease, Alzheimer's, macular degeneration. if the body has a methylation problem and doesn't methylate properly and their homocysteine is high, there have been studies to show that B complex, B vitamins, B6, B12, and methylfolate can be helpful and decrease the risk by about 40%. Is that something that you have a test for?
I don't have a test in my office, so I have to lean on you where you were in a sense going with that one. So
So yeah, I mean, sometimes, we do labs, and if we see the homocysteine's high, C-reactive protein is high, we know that they're increased risk for Alzheimer's, cardiovascular disease, and anything with inflammation, such as macular degeneration. In fact, Joanna Seddon at one time wanted to put together like a little labs for macular degeneration, which would include that. I don't think it's ever happened, but it's interesting because if someone does have high homocysteine, those three, but it's good to put them on a total B complex, will decrease the risk.
yeah,
Now,
there are some people that have some, younger patients that get like a vein occlusion, and it could be due to homocysteine levels being high. And I've seen the B used on that, but that was really that's why I love doing this. And I don't claim to be a know-it-all. That link with macular degeneration certainly sounds reasonable.
yes, I've seen it as well, patients that had little vein occlusions and working them up, and it was from high homocysteine. I've also seen it from high LP little a, high elevated insulin, to 2-hour insulin. So there's a number of reasons. That's one of the reasons I started doing labs myself, is because I'd see little hemorrhages, I'd send them out, and I always come back, there was nothing wrong. Well, there's 1,000 biomarkers that you could do, so you kind of have to pick the right ones.
Right.
So let's end this with back to, how do we treat neovascular membranes with anti-VEGF injections? Talk about what a neovascular membrane is, which I think you've already talked about it, but just to review it, and what are anti-VEGF medications? Where are we going with these injections? And are there side effects? What are the side effects? What have you seen?
Yeah, so to the first part of your question, we'll kind of highlight what a choroidal neovascular membrane is, and it's really we talked about that RPE breaking down. There's a signaling process going on. The body tries to heal itself. It tries to heal itself by growing a new blood vessel. Now, the drawback to those new blood vessels, it sounds like a great idea. They're just poorly constructed. They're not like the blood vessels that we were born with. They're poorly constructed. They like to bleed really easy. So the good news about these poorly constructed blood vessels is that they have a certain marker on them that not the normal blood vessels have. So that allowed the scientists to go in and target that with what you were saying, these anti-vaso-endothelial growth factor, these anti-VEGF injections, which are a biologic. And I do a lecture on biologics, and biologics are different than different medications. So, like aspirin is a chemical structure, and they're really, really tiny. Biologics are huge. That's why a lot of times they need to be infused. Like Humira is a biologic. You hear a lot of these treatments for psoriatic arthritis, they're biologics. Steroids, you kind of hear that a lot. That suppresses the whole immune system. Biologics are super, super targeted. They just target one little specific, and that's that. Remember, I told you there's a difference between a regular blood vessel and a choroidal neovascular membrane. It has a marker. Smart people out there figured it out that if I can go in and just target that, I won't kill the normal blood vessels, but I will kill the bad blood vessels. So, they started off by, biologics that needed to be injected maybe every few weeks. And you ask, where is it going? They're trying to develop these anti-VEGF, these biologics that maybe can last a lot longer, maybe 3 to 4 months, and that's where they're going. But biologics are just there. A steroid is kind of like an atomic bomb going off, but a biologic is like a guided missile and just going in and just hitting very targeted tissues. And that's why they're extremely important, better than going and burning out the laser like what I grew up on or what I was cutting my teeth on getting into optometry school. Yes, you have this choroidal neovascular membrane, and yes, you're about 20/60 right now. I'm going to burn a hole in your retina to kill that, it's going to take you to see the big E, but trust me, it'd be a lot worse. That was a little tough to sell back then. I'm glad the biologics or these anti-VEGFs are out, because you can at least, maybe the patient's on 40, 80 injections, but it's killing that bad weed and maintaining and keeping the patient's vision.
And how often do they have to have one of these injections?
Yeah, it all depends on, how many cracks we talked about in that RPE. They have different protocols out there. Treat, some are, three injections in a short period of time, meaning weeks, every 3 to 4 weeks. And then they get to a treat and then extend. They get them out to 10 weeks or 12 or 11 weeks or 12 weeks. Everyone's a little bit different because the amount of damage and signaling that's out there. But, I would say probably the longest patients that, if you want to say, that have active or maintenance, they're probably getting injections once they get out to that treat and extend. They're probably getting injections about every 8 to 11 to 12 weeks, which is, that's a lot of injections throughout the course of the year. And you mentioned about side effects. The biggest, risk that would be you're sticking a needle into the eye. And the risk would be an infection into the eye, maybe if the technique isn't right, a retinal detachment, some floaters, some increased pressure, some pain in the eye that whenever they're doing it. But not a fun procedure, but at least it's a sight saving procedure.
Every patient wants to know, you're injecting a needle in my eye, does that hurt?
Yeah, everyone wants to say that, right? Wants to ask that. The good news is they've got the techniques out there that they can numb that eye pretty good, and they don't feel it. So those needles are tiny, and then they numb the eye pretty good. My father-in-law, he's on his 83rd injection. He's a tough guy, but when it comes to his eye, he's probably the biggest baby out there. But he's able to get it done because it saves his vision.
So when people have cardiovascular disease, sometimes they'll make collaterals that'll actually protect the heart. The body will produce a natural bypass around the plaque. Will these injections affect those collaterals for those type of people? They're making these collaterals. Are they very similar to these weak blood vessels that are in the eye, where those people are at risk?
I'm familiar with collaterals in the eye that are formed from vein occlusions. When people get a vein occlusion, a collateral in the eye it's just a smaller blood vessel that's already existing. It just becomes opened and trying to bypass. So I always tell the patient, it's kind of like, they put a highway in by me. So I have old 22 and new 22. I can always tell when there's an accident on new 22 because old 22 and they're bypassing everyone. And so those are the collaterals. I know of neovascularization in macular degeneration. I'm unfamiliar with, Carrie, I'm going to have to use your help here. I'm unfamiliar with collaterals and the VEGFs being affected there because they're normal blood vessels that are opening up. So I would say that the collaterals in those retinal conditions would, in a sense, be safe because they're not being targeted.
Oh, I appreciate that. I want to thank Dr. Greg Caldwell for joining me today. If somebody wants to find out more about you, how could they do that?
Yeah, pretty easy. My email address is grubod. So my nickname is Grub. So GRUB as an optometrist, OD. So grubod@gmail.com. And, I'm not opposed to anyone texting me or giving me a phone call. So 814-931-2030.
I want to thank Dr. Caldwell for joining me today. He's a wealth of information, and he's one of my favorite lecturers. If you're in the vision community, ever get the chance to see Dr. Caldwell lecture, go see him lecture. He's fantastic. Dr. Caldwell, thank you for joining me today.
Carrie, this is, you asked me to do this, and it's been the highlight of the last week or so that you've asked me. It's truly an honor and a pleasure. And I would not be a good guest if I didn't thank you for inviting me, but then thank you for everything that you're doing out there, bringing the awareness to patient care, bringing the technology in multiple forms for patient care and for community. So thank you for all you do.
Well, thank you, Greg. And this is Dr. Kerry Gelb for the Open Your Eyes podcast. Everybody, please stay well. Fitting multifocal contact lenses presents a big opportunity to meet patient needs while growing your practice. Alcon is your partner not only with our innovative portfolio, but through e-learning. Learn to enhance your multifocal strategy today with the Alcon Experience Academy.
Since I bought Safe For You, my dad makes me clean his boat.
Es natural y es un buen producto.
Every time I go back to school, my mom always makes sure that I have my Safe For You products. I bring extra, and my roommates certainly don't mind.
It's a good thing I had Safe For You to clean up after this little guy.
When my hands get dry, I like to wash them with Safe For You.
And most importantly, the reason why I buy Safe For You is because it's safe for me and you.